Today we're talking about tomorrow actually, I guess, we're talking about personalized cancer therapy and focusing on breast cancer. Although in general I'm a very positive person, the talk I think focuses on some of the challenges of personalized cancer therapy in breast cancer. We all have a lot of enthusiasm for personalized therapy. There's quite a bit of buzz and hope, but I think there's clearly some hype and unrealistic expectations. So I think it's very important to recognize the challenges so we can address those in our clinical trial designs, as well as our day-to-day clinical practice and in patient interactions. When we talk about precision medicine, we're talking about multiple facets of this. And for breast cancer, all of these areas are rapidly evolving. There's, of course, a tremendous amount of momentum already surrounding cancer risk prevention, prediction, as well as how we can select patients better for preventive strategies. And of course, with the advent of next-generation sequencing, there's a lot of momentum regarding multiplex testing for not single genes, but a variety of genes with different risk implications. There's a lot of momentum in the prognostic area, especially for adjuvant therapy. But the area I think in our own program we've been primarily focused on is cancer prediction for therapeutic sensitivity. We've had a lot of emphasis, both at our own institution at MD Anderson as well as in other institutions, looking at genomics in this arena, partly because it's been the low-lying fruit, although I think we're all recognizing that diseases, breast cancer, like breast cancer, are multifactorial, and even those patients that have a genomic driver have multiple genomic alterations, and how we can bring that to therapeutic effect has been somewhat challenging. Now, we've definitely had, I think, some promising hits, like alterations like EKT, HER2 are very compelling. In contrast, I think we're still trying to figure out how we can best leverage other findings like p53 mutations, which we recognize are common and have significant prognostic relevance. One of the approaches that we've taken is also to try to explore trying to make decisions in the neoadjuvant therapy setting. In the adjuvant therapy platform probably has been best developed for breast cancer, where the goal in part is to try to cause downsizing, downstaging of the tumor, looking at are there therapies that we can add or substitute to get higher rates of complete pathological response? In many tumor types, there's already been successes where combinations with novel therapies have had a signal of efficacy. And in our institutional program, the MD Anderson Moonshot program, there's been an emphasis in the triple-negative breast cancer scenario where we are looking at patients that are resistant to adjuvant therapy, to the standard neoadjuvant therapies, and then patients are allocated to different treatment algorithms based on both molecular characteristics as well as really capitalize on opportunities from new emerging therapies. This is a very exciting program that's led by Dr. Stacy Mulder in collaboration with Dr. Fraser Simmons from pathology, with each treatment arm is led by a different investigator. So that, I think, makes sort of a group team science approach, and it will give us opportunity to identify whether new therapeutics will be more effective than the existing therapies, which in patients where we don't expect them to have significant response, because patients that are more resistant already to the initial treatment regimen are being allocated to these treatments. So we're also using this to learn more about the biology, not only looking at predictors of response, but also looking at the residual disease. We've had an ongoing program looking at molecular characterization of tumors that have not responded to chemotherapy, and not just doing observational work, but also generating patient-derived xenografts. Patient-derived xenografts, I think, are, as you know, an emerging area where there's a lot of excitement because we feel that maybe PDXs developed are a little more reflective of the heterogeneity in tumors that we see in humans. So that's where by doing molecular characterization of PDXs, we can better look at novel therapeutics to identify more effective regimens. That's an excellent question. And in a recent paper we published, actually, we looked at the genomic profile of serious triple-negative breast cancer patients, and every patient had a unique genomic profile. And if you start thinking, I think, of it that way, clearly it demonstrates the challenge. But I do believe that clearly to bring treatments to bear, we need to look at combinatorial therapies, and we need to have safety data for the combinations. So likely for these patient populations, there is going to be a handful of key combinations that will be effective, or that's what we're all hoping to identify. I think this is a great time for institutions, both academic as well as commercial, to work together in partnership, of course, with our patients to really enhance clinical trial accrual and to have greater access to the opportunity to do combination therapies.